Good morning and welcome to Cancer Medicine Grind Rounds. I'm Bob Wolff, Cancer Medicine Deputy Division Head and Professor in GI Oncology. Today is our Gerald P. Bodey Sr. Memorial Lectureship. Dr. Bodey began his career at MD Anderson in 1966, working to develop the adult acute leukemia program. From 1975 to 1983, he served as Chief of Chemotherapy in the Department of Developmental Therapeutics, supervising studies of more than 30 new anti-tumor agents. In 1981, he was appointed the first director of the Office of Protocol Research. Bodey was the first recipient of the MD Anderson Faculty Achievement Award in Clinical Research. A pioneer in the study of infections and neutropenia, Bodey became the first chief of the section of infectious diseases at MD Anderson in 1975. He semi-retired in 1995 and subsequently passed away in 2020. Introducing today's speaker is Dr. Dimitrios Kantoyanis, the Robert C. Hickey Chair in Clinical Care and the Deputy Head of the Division of Internal Medicine. He is considered the leading mycology expert worldwide with an H-index of 137, over 700 publications, and 80,000 citations, and is listed in the 1% of the most highly cited and influential researchers in the world. Dr. Kantoyanis heads the European Confederation for Medical Mycology Center of Excellence, which holds diamond status, the highest designation awarded by the ECMM. MD Anderson remains the only U.S. institution with this prestigious status, reinforcing its leadership in medical mycology. Before we begin, let me remind you to please submit your questions in the Q&A section, which will be moderated by Dr. Kantoyanis. Also, don't forget to claim your CME credit through the professional education portal. Thank you all for logging in this morning. I'm handing off to you, Dimitrios.
Okay. Thank you very much, Bob, for this wonderful introduction. And as you said, it is a special lecture for all of us. I'm very happy to introduce my longtime colleague and good friend, Professor Oliver Cornely from the University of Cologne, Germany, as this year's recipient of the Bodey Memorial Lectureship. Dr. Cornely's training is impressive as he's board certified in internal medicine, infectious diseases, hematology, oncology, emergency medicine, and holds degrees in medical mycology and travel medicine. Oliver is a major thought leader in clinical research in oncology, hematology, ID, a practicing oncologist and hematologist who is credited with practice-changing clinical trials for the treatment of infectious complications in cancer patients. His leadership in a variety of clinical trials of many important anti-infectives in oncology, not only in mycology, but also C. diff, antibacterial resistance, quality improvement, influenza guidelines, impactful registries. He's behind the very important registry called for fungal disease, has been sustained and impactful. He has held important leadership positions, and he's the president-elect of the International Society of Human and Animal Mycology, the largest mycology society in the world. He's a prolific scholar. He has an H-index of 119, over 60,000 citations, and over 700 peer-reviewed publications, and he also ranks as top 1% cited researcher for the last 7 years. On a personal level, Oliver is a wonderful, classy individual, dear friend. He helps everybody, a real team player, and he's a very worthy recipient who reflects the enormous legacy of Dr. Bodey, who was the interface of infectious disease and oncology. The title of his lecture today is Hematological Cancer and Infectious Disease, Navigating Our Patients Between Scylla and Charybdis. Oliver, take it on.
Thank you very, very much for your really kind introduction. And I will start sharing the screen now. And um, so here it should be visible now. So it's a tremendous honor and to receive this award. Um, and indeed, I grew up with reading papers from Gerald Bodey and from MD Anderson. So um, the okay,
We cannot hear you, Oliver.
yeah. So
Yeah.
some technical difficulty, maybe because of the 14 time zones that are separating the two of us. Um, so the hematological cancer and infectious diseases, and I call it navigating between these two because on the left-hand side, and I will come back to archaeology, it is Scylla, and then Charybdis is too unsettling to show. So it was a maelstrom where ships got lost, and that is these two where we need to keep our patients safe in between while we treat with chemotherapy and with modern treatments and learn more and more about patterns of infectious diseases that keep to grow with the new therapeutic modalities. So, um, lots has been said, and everybody knows, of course, in and outside of Houston, Gerald P. Bodey, uh, I would call him a global, today it would be a global influencer, right? So, a word that is relatively new, I'd say. And, um, and he impacted on my personal development and my work enormously, although we we have I mean I knew him, he didn't know me, I guess, I'm not sure, but we didn't really meet, so we never spoke together, we never discussed something in person, unlike many of you, which is really a privilege. So there is this saying on building on prior knowledge, right? So which goes back to Isaac Newton, so another giant. And between these yellow arrows, actually one can read it, the handwriting of him that he says, if I have seen further, it's by standing on the shoulders of giants. I'll come back to that because I neither compare myself to Newton nor to Hooke nor to Bodey. So the first articles I read on the topic of infection, and that was in 1995 when a position became vacant because somebody left our hospital and who was taking care of the infection. So, and my my mentor, whom I did my doctoral thesis with, he said, "Well, you know what? I think there is a need for caring for infections in hematology patients." And so the first articles I read, and that is back then before the National Library went online. Okay, so it was really paper articles, were like this one from Bodey and team and JAMA in 1964 on the use of gamma globulin. And when you dig into the publications and the research areas of Bodhi, you find like everything that is still important today. This is just an example in one of the oldest articles, and then there's this nice saying, and thank you, Dimitrios, for leaving me that picture of Emil Freireich, that 90% of what we hold true in cancer research and clinical care will be obsolete in 10 years. Well, I can say if 10% of what an individual contributes is long-term relevant, then that is a lot and a lot to build on. And for Bodhi, it's definitely more than 10%. So, for example, we currently build this one on findings of Bodhi from the 1960s because, as you know, the intravenous immunoglobulins that we give to CLL patients, for example, we do that, or the licensing is not for primary protection, primary infection prophylaxis, but for secondary. So this is a current study where Susan O'Brien and I am involved in, and had the pleasure to design this one. And we had to go back many, many years to these publications that I just mentioned and others to come to a reasonable design and how to define endpoints, etc., for this currently enrolling study. So other landmark studies are this actually 2 year older than I am, this paper, and with the causes of death in acute leukemia and the 10-year study on these 414 patients, a landmark groundbreaking study which showed that what the meaning of infection is and that once hemorrhage finally became more and more controlled, infection took over, so to say, as a major cause of death. And so, so it's all about bridging between these disciplines. And there's not a lot of graphs in the literature where hematology and infectious diseases are mentioned as these competing risks of death, or Scylla and Charybdis. And so Dr. Bodey certainly being a pioneer, and I think that is a good term because pioneers are the guys on whose shoulders we stand, and he bridged between these two fields of ID and hem-onc. So I guess there are only like about 10 people who have been board examined in both because it's a somewhat unusual way to build a career. But it gives good street credibility, as I call it. So, very basic questions that we today need to think through when we design clinical trials, which is about 50% of my time, it's designing trials. And so, who's at risk? The backbone things here. Granulocytopenia, who described it? We all know it's one of these papers. And where granulocytopenia was, well, exactly defined as a relationship and as the predisposing factor for infectious diseases. What was lost and not that much referred to over the years is the other part of that same paper with the lymphocytopenia, which is super important and in the context of fungal infections that is rediscovered every once in a while, although it has been described 50 years ago. And but somehow it is sort of lost knowledge, so to say, and it would be easy to just read these papers, and there it is. So with these definitions of what is neutropenia or granulocytopenia, etc., that is the first step because otherwise you cannot define all these clinical entities. What is fever of unknown origin? Yeah, sure, you can say, I don't know what it is because it's unknown, but if it comes in the context of 500 or less, for example, as a cut of neutrophils, then it is a totally different story. And it's an indication on its own, and multiple studies were done in that indication, but just because of that groundbreaking 1960s work. We do then have the clinically defined infection, the microbiologically defined, and the combination where we really know what we are treating. That's the last line. Like clinical, we know the organ, and we took the right sample and found the pathogen. So enabling such new indication of febrile neutropenia goes back to his definitions, and the MDI and CDI that I talked about are the other two groups. We want to have that part, which is usually in the studies back then with limited diagnostics. It's only a tiny fraction where we do have CMDIs. And ideally, we would have only a tiny number, tiny fraction of fever of unknown origin where we empirically treat, blindly treat, maybe polypragmatic with 5 different drugs at some point if we never manage to find a pathogen. If we do find a pathogen, then that falls in the MDI category, and that is, of course, all the bloodstream infections, for example. If we do the sampling as it was advised to do, and as it's still being advised to do, then it's astonishing in how many patients we really know what we treat, and we are not flying blind. The vast majority of patients across all indications, inside and outside of hematology. So once we define the diseases, we need to define what is a success and what is a failure, because otherwise no clinical trial. I don't want to go too much into detail with that one. It's a bit dry, maybe, but once the definitions were there, we finally were able, or colleagues back then were able to compare the results of, for example, febrile neutropenia studies. Here, this was a discussion in the New England Journal between MD Anderson representatives and scientists and clinicians and ERTC and others, where it was about combination antibiotic treatment for gram-negative. So 1988, big topic. So maybe a topic that might return. And it was the prior organization, the of the MSG, the BAMSIG and ERTC and others discussing this. Finally allowed to do cross-trial comparisons and able to do so. Really important steps, but they all follow these initial steps. And still, after 20 years, thought leaders are still the same. So, um, how to transfer that, how to apply the what was learned and developed in Houston to Cologne, um, and to our epidemiology. Two slides just on where I work. It's the University Hospital of Cologne. It's one of the top-rated university hospitals in national and international rankings lately, in recently that Newsweek ranking. It's 1,520 beds, and the other numbers are here. So it's a pretty standard sized university hospital in Germany or in Europe. Clinical trial activity is pronounced, and that is part of my responsibility actually there. We have a bit more than 500 active clinical trials across all different specialties, medical and surgical specialties. 10% roughly are phase one, and there are 85 study nurses. So it's a nice environment where you can do a study. If you have an idea, you find the funding, you can do something. So um, one of our early observations back in 2001 was the first time that bacterial translocation in neutropenic sepsis was shown in an image and not in an animal model or as a hypothesis. So from left to right, just briefly, and this is autopsy, unfortunately, autopsy material here. Left, you see this ulcers and necrotizing enterocolitis and the submucosal hemorrhage. And then doing the histology, and one of these spots is the middle panel with three black arrows that point at bacteria in tissue. And then all the way to the right, there is one vessel. You can actually find that vessel on the middle panel as well, but now we zoomed more to a higher resolution. And this is a bacterial growth, of course, post-mortem. The bacteria continued growing, but they were found in the blood at polymicrobial sepsis in that living patient as one of the last analyses done on during her life. And you see the hyaline thrombi, the DIC, as part of the sepsis that the patient went into. So translocation in flagranti, so to say. So what we now did with the principles is we applied them to our local epidemiology, and look what we could compare here. It was ceftriaxone became after this our standard after this study. And you can immediately realize that apparently we don't have a Pseudomonas issue and in our first line treatment for febrile neutropenia, which was the indication for this study. So we used the principles and came down from 3 times daily cefotaxime combination with aminoglycoside to more simple once daily regimen. Then we tested this versus new drugs, cefepime, for example, and did a little series of such studies. And then we started to build subgroups and then treat subgroups only orally or other subgroups, try to improve their response to febrile neutropenia treatment, and this is autologous stem cell transplant here in an RCT. So, um, but while we did that, there were more papers coming from Houston, and that is that fungal infections in cancer patients all of a sudden became more and more interesting. And I recall patients around that time, 1990, end of 94, beginning of 95, where we had Aspergillus bone infections in leukemic patients, and we had no good tools to treat this. And so we could, uh, if we were just doing the diagnostics and just trying to really solve the that miracle of the individual patient, what is causing the fever, then we do find then we do find invasive fungal infections. And of the fungal infections that were found and reported in this autopsy survey of the 1980s was Candida leading, followed by Aspergillus. And I love the conclusion. The study clearly demonstrates that fungal infections represent a common complications in patients with leukemia. Indeed, yes. And there were no more studies then coming from, well, at some point, I guess it makes a lot of sense to say this one was until 1988. So now let's follow up and have a look at the next 15 or so years. And we see a diversity of fungi. It's like everything grows on our and in our patients. But the big chunks are, of course, then Aspergillus and Candida. And for Candida, very early on, it was already shown that non-albicans Candida in this study, now um, led by Dimitrios and group, that this study showed us that non-albicans is the future. And to some extent, I think um, you have such a unique population and such uniquely high patient numbers that you treat that if we look at what MD Anderson publishes, that is for many other centers the future. So we can have that look into the future and what will we see and what have we to expect is usually the future of the others, what you see during presence. So the um, Candida and Aspergillus, and we know that there was fluconazole being developed and fluconazole being used in hematology, specifically in allogeneic stem cell transplant, the Goodman and Slavin studies in 1990 and 92 or so. Um, but that was basically it. So 20 years, 50 or more studies, randomized clinical trials, about 9,000 patients, no answers beyond fluconazole, 400 milligrams once daily in LOSAT. And so we did this literature analysis trying to understand what could be done prophylactically because the treatment options were still very limited. I mean, this is before we finally got voriconazole. So, and building from there, we again had to go back to the definitions, and the question was, are the definitions still relevant? Galactomannan index, sort of microbiologically documented infection, CT scan, CDI, clinically documented or defined infection. And I would say if you take these, they are basically something like possible IMIs and not more than that. But if you add them up, you have that MDI and that CDI and the combination, and that is a probable invasive mold infection. So it has a direct line from the 1960s, 70s, all the way to today. And we just give it different names, possible, probable, proven, etc. But it is still the same concept. And it's a general concept throughout infectious diseases and not only in hematology, but there's where the structure and the logic comes from. So with that analysis on all these different drugs that could be used or that were used in prophylaxis, in the end, the only result was fluconazole, as said, in allogenic stem cell transplants. And nothing that one could really defend for febrile neutropenia during induction treatment. That was actually an ideal situation. The lack of clinical studies that made a difference in the latter population, and with the knowledge and work in the antibacterial space and the clinical necessity to prevent fungal infections, we then went to design this study and posaconazole with this improved efficacy versus standard fluconazole or itraconazole. One could even have used placebo, but even versus these presumably active drugs, posaconazole had that superiority in the protection from fungal infection, and that actually even, as you may know, translated to the lower probability of death for these AML induction patients. So um, that's the first and so far the last study on prophylaxis in patients with neutropenia that changed guidelines. And it's almost 20 years ago. And when um, preparing for today, I thought I should share my thoughts on why did this study work so well. Okay, so well, number one is there was no study before that would really yield an A1 recommendation type of support in guidelines in that indication. And then there was posaconazole. It was a new drug without a future. Without a future because nobody would treat invasive aspergillosis, for example, with an oral suspension. That would be highly unlikely as a first-line treatment. And it was too expensive um, for athlete's foot. And that was the two indications that had been thought through by the company back then. But we had that unmet clinical need. And we had very simple inclusion-exclusion rules so that the patients, whoever came, had a high likelihood to fit into the study. And so at the same time, that means that we would have a study population that is very representative of leukemic patients that we treat. The industry partners understood and were courageous enough to not dump the drug, but to go for that new indication that, apart from that fluconazole example, was not a very common indication to follow. And then it had some sort of magic bullet PK/PD, which was unknown by the time when we designed the study. So that's the little portion of luck that you need. And specifically, the effect on survival was larger than the effect of invasive fungal disease. That tells something on the completeness of our diagnostics and was another unexpected finding. But we did actually build it into the protocol so that we were allowed to analyze this. So is that then the end of the story of the prophylaxis? No, certainly not. We have the drug-drug interactions, and we have more and more of these. We have emerging resistance. We have even new diseases that we didn't know before, and new forms of fungal infections, and of course, newly diagnosed and newly found pathogens and new types of immune suppression. So there is a lot to do. And this is not meant for reading, not for human eyes. This is an overview, a table from a Cochrane analysis that was published 3 years ago from Yannick Stemmler and a large group. And the Cochrane analysis to understand what is in the literature and give a recommendation for all the new anti-leukemic drugs, because these patients will need protection from fungal infection. So what is the advice? What could be done? And there's not a lot out there in terms of evidence. And by the time the thing was published, there were likely two new drugs already given to our patients. So it's a never-ending story. It's not over. And I like very much that this, Demetrius, that you gave this one to me. It is not knowing what you did, but it's basically the story of this presentation, and it's a figure for CMI, and you allowed me to share this here. I don't know whether that paper is yet out in CMI. I think it's in print, and so it's the story from the 1960s and what the problems were that we were dealing with. And it was changing from Staph aureus to gram negatives to fungi. And we will see more and new aspects and new problems in our patients that we don't know yet. That is why there is the question mark. That's my interpretation of your figure here. And that comes with targeted therapies, with for hematology, of course, and with immunotherapy, and actually with other patient groups that are not hematology patients, but are immune suppressed with any of these modalities, and the hematologists are being asked how to deal with these and how to manage these diseases. So the new the new problems that we see that we are facing is the neurovascular complications by iatrogenic Fusarium solani meningitis. I took that example deliberately from outside of oncology or hematology, but it nicely depicts what the pathogens are that we are dealing with. There's not a single drug on the market that you would want to use to treat this pathogen, this patient. And so now we do see in official recommendations how to treat that there is a recommendation for the combination of amphotericin, voriconazole, both will not be working in this pathogen, plus manogepix, a non-licensed drug that you have to ask from the company. That is unusual, and it tells us that we are a bit in trouble, and that is the same for our hematology patients, because that is where Fusarium usually is causing the invasive infections. And then there are these, until recently, rather boring pathogens like Candida parapsilosis, easy to treat and done, no longer because now they are resistant. And we have this outbreak. There's a number of outbreaks out there, but I just took one from Germany, from Berlin, um, where there were 15 hospitals involved. And I call it a mycology thriller because they really did a good job from the National Reference Center. They investigated this like CDC would investigate it. And they really made the connection between 15 hospitals and only 33 infections, plus a dark number. And it started with two physicians who were alert to what causes disease in their patients, to orthopedic surgeons, and they had two Candida parapsilosis patients several weeks apart with a similar susceptibility pattern, with this pattern on the slide. And that is how the thing was triggered. So we need to keep our mind and our eyes and ears open. And then we can still discover new diseases. That's crazy. It's mucormycosis, but transdiaphragmatic. We created that word, this descriptive word for it. And the question is why we described three cases and nobody else. At least I didn't find anything in the literature. And the lesson that we can take from here is that we, first of all, need to review the CT scans ourselves. So that is, I guess, what hematologists anyway do. And don't only look at the lung window. So if there is a process that is not confined to the lung, but a process that touches the pleura, and then we need to do a soft tissue window or an MRI and see what else is happening. And here it's growing, and no cancer does this, and certainly no bacterial pneumonia. So mucor is causing pneumonia and growing through the diaphragm into the spleen. The other two patients, it was on the right side, and it invaded into the liver. So that's difficult to treat, and you need a lot of really good surgeons in whatever sequence and lots of discussions. And you still need to be fast because mucor is growing. So I hope that some centers might just review their mucor cases and check whether they found this as well. I found a fourth case a few weeks ago, a hairy cell leukemia patient who did not receive prophylaxis because there is no tradition and no study, of course, for antifungal prophylaxis, and developed that such a pattern with the mucor rhizopus. And then we do face another layer of issues, and that is the flucytosine shortage. And the same as it's just an example for drugs that are all of a sudden no longer available, which is um, yeah, of course, a big problem because we don't have lots of choices in the antifungal space anyway. So it's increasing complexity, and 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 with increasing complexity, we need more guidance and on these different levels, local, regional, global. And um, what we just did set up a few months ago in for Germany is that we advertised by word of mouth that they could call us or better write an email, and we would give them a multidisciplinary answer on the fungal problem they found in their patient. And so it's mostly physicians from Germany, some from outside, and we do 10 minutes rather than 15 per case because we are overwhelmed with cases. There are so many patients and so many physicians who do not know how to treat these, and the slightest omission in managing these patients can have consequences on their well-being and on their treatment success. So we have now a catchment area. I did this in quotation marks of the entire country, basically. The advice that we give is based on the guidelines, and they were briefly mentioned earlier today. And just the international, or how we call them, the global guidelines, and quite some of you are part of the global guideline program. It's about 400 authors and contributors around the globe, and we usually publish them in Lancet ID since 2019, since the mucormycosis guideline. Candidiasis was just published there, and aspergillosis. We started the writing process, and it's a we all need to work together for that, and we have colleagues from 10 or more different disciplines contributing their knowledge, so that we end up with a really useful guideline. It will be books, the guidelines. So this is how these guidelines look like. This is in the happy situation where you have all treatment options available, and it's for mucormycosis. And there are diagnostic schemes, treatment schemes. But what if one of the drug classes is missing? You don't have that problem. We don't have that problem, but the majority of countries does have that. The majority of settings where there is not all options available. And if you just take away one, let's say amphotericin B formulations, then it almost becomes legible, the slide. And who doesn't have decent amphotericin formulations may lack POSA and isobuconazole as well. And more of these green boxes in this traffic light color scheme are then missing. And there are entire diseases where there is no green box. There is no standards, nothing where you say that's the way to go. When we issue these guidance documents, then we want to have some sort of readout because guidelines need to be analyzed on whether we can quantify the adherence and measure whether guideline adherence is any good or not. Because there is an ongoing discussion whether or not, so I'm not treating a guideline, I'm not treating a population, I'm treating this individual type of argument. And still, one could quantify the guideline adherence, and we can do so with scores where we give different decisions in diagnosis, first line treatment, and follow up a number of points, and then you just collect the points during the journey of the patient, and it reminds you as a either as a pocket card or as an app. It reminds you of the things that are important to do. We have this as an app for candidemia and for Aspergillus mucor in the making. That's still a PDF. And then the guidelines bring up a lot of level three recommendations. So, which is just the level of evidence for an opinion of a respected authority or a case report. So, the what is the weakest evidence, and of course we won't see a lot of randomized clinical trials for mucor or any other of the rare diseases. And what we what we do is we identify all the level three in the guidelines, and that means we have a list of individual situations, clinical questions that need to be improved to level two, at least a series, or then next step, a comparison of different series of patients. And what we do, where do we get the series from? Because quite some are so rare that a single hospital doesn't have enough cases and cannot establish a series. So for that, we use Fungiscope, the registry that we started in 2003 and which is now active in 96 countries. And there are an increasing number of cases in there, so that even for really rare situations, really rare patterns of specific organs being involved with a specific pathogen, we do have a decent number of these cases and they can be analyzed. And there's like 100 papers can be written out of this database. But that is more than Cologne alone can do. So we are happy with other people contributing and then writing these papers as well. So this is now not only part of the package for isavuconazole back then, where isavuconazole was licensed for the first-line treatment of mucormycosis. Part of it was the external comparison to well-matched cases in hematology from the Fungiscope registry, who were treated with amphotericin and didn't differ in all-cause mortality because that is the readout finally. And it's now being used and accepted by FDA and EMA as all-cause mortality benchmark, for example, for the one or the other of the new drugs that are currently in phase 3. That's another dear friend, Francisco Mardi, who passed away a few years ago, who published that comparison of the 21 isavuconazole first-line treated patients and the 33 matched amphotericin B patients who had a similar risk of not surviving mucormycosis, and they almost all had a hematological malignancy as underlying disease and key risk factor. And that is how that's the volume that these guidelines have. It's 104 or 105. I at some point I stopped counting authors, and we make sure that they are from all continents so that we get these different settings of all diagnostics, all treatments available versus some holes in that armamentarium. And it's hundreds of pages and thousand and more references. And it's nice that the world works together here with 73 endorsing societies and the three societies at the in the foot line, the ECMM that was mentioned, and the ISHM and the American Society for Microbiology being the drivers and leading this effort for Candida and some others of the guidelines. Well, coming slowly to an end, the contributions to the field of infectious diseases and immunocompromised cells from the group in Cologne is depicted here, and it starts in 1994 and 1995 when I went to the library and read 30-year-old papers because that was the decent way to do and to build this on because it was simply the yeah, the foundation, and the foundation doesn't change. It's there, and almost everything we do always goes back to this, and to how approach patients with infections who are immune suppressed. There are two communities that I'm embedded in. On the left is my wife. She's an archaeologist, and that is, I asked her for a picture of Scylla. So that is on my first slide. That's basically her slide, and our kids. And but I think that I spent way more time with than with the family. I spend more time with medical sciences, where everything is teamwork. And I'd like to acknowledge the Cologne players. So Matthias Schrappe, you may not know him, and he's retired for quite some years now. He was the person who said, "I think there's something with these immune suppressed patients. You should try to do something in that field." And the same for Gerd and Uli, and Michael Halleck will be well known to many of you because of his work in CLL, I guess, and he's the head of my dear colleague and head of the hematology department. And the Cologne team working on these studies, which is a moving target of about 120 people doing clinical trials, designing trials, and executing them with a strong focus on infection. And then the national players, as I would call them, and the global players in alphabetical order. Arun Aloke from Chandigarh, India, and Dimitrios, of course, Houston, Texas, and Jacques Mais in Brazil. Three who are close friends, and I'll say a word on shoulders. Then the collaborators in the 96 countries, usually coming through these three organizations listed here. And then I said, oh, well, how many co-authors do I have? And it's actually 3,192 individuals, not nobody counted twice, so to say, and the funding agencies and industry collaborators. So if I may, I want to give a little twist to that standing on shoulders. I think we are standing on the shoulders of our peers, of the pioneers, but the peers as well, because everything is teamwork. And but still, we have to learn and to read the roots of these fields we work in, and they date back, in this case, to the 1960s and thereafter. Thank you very much.
Thank you very much, Oliver, for this beautiful presentation and tour de force view of the field. We have time for questions. As people get, think about some questions. I'm still on this leukemia service, my last day today, and reflecting on your talk and reflecting of what has been accomplished. In a way, paradoxically, the easiest things have been described in mycology, like the role of neutropenia and infection risk. I see patients now with functional neutropenia, people who got sequential chemotherapy, CAR T cells, steroids, some compounds we never heard of that knock off monocytes. And that begs the question that I think the mycologist of the future needs to have this niche area, how to calculate immune deficit more than what Bodey has done in the 60s. And what will be the tools to do that coming from our traditional background like you and me come? Is it immunogenetics? Is it ex vivo functionality? Is it blast characterization? Because that has become a niche area now for risk stratification, at least at MD Anderson.
Mm-hmm. Yeah. Couldn't agree more. We know that saying of the net state of immune suppression, but that is not enough, right? We need to differentiate within. I was talking to a colleague who works on vaccine response, which is an area that we went into a while ago because of COVID, and I didn't mention that. So, vaccine response and a meticulous analysis of who are responders and who are not. I think we can learn from that direction because if there is a frankly neutropenic patient, it is very difficult to analyze cells. And yeah, maybe blasts, maybe all of the above of what you mentioned. I believe that we there are some low-hanging fruits that were not picked, and that is the vaccine response. This is one of them. We didn't really explore into vaccine response in all of our patients. So, but that is a very easy way to rapidly learn. It will
Dr.
not,
Wolff had a question. Yeah.
yeah, yeah.
Yeah, great talk. One question I would have is, can we risk stratify patients somehow through their microbiome, through obesity, location where they live, right? The southwestern United States, southeastern United States, whatever, in Europe. Are there ways for us to sort of risk stratify patients at higher risk for either bacterial problems or fungal infections or whatever in this population?
Hmm. Well, it goes in the similar direction of what Dimitrios addresses, but you now expanded this to environmental factors, if I understand correctly. So, where do they live? And we know that there are pockets like Aspergillus terreus with only two, three spots where that is found. Um, so it would be a really comprehensive analysis of the individual patient. And I
AI can
mean,
do it. AI can
just very,
help.
Yeah.
very practically, a CT scan when leukemia is being diagnosed.
Mm, mm,
So instead of saying hello, CT scan, a baseline CT. I don't know whether you introduced
mm,
that in at MD Anderson, but there are a few studies who address that and say that is a way to detect disease.
mm,
It's not who's at risk because
mm.
that doesn't answer the question, but at least we would further down the road see who has already an incipient aspergillosis. So Dimitrios, it will be a lot of work and a
Yeah.
lot of, I
Actually,
don't know whether it can be tackled
actually, we're
currently.
trying to do that with J.R. Thompson. We're looking in ad hoc analysis of CTs of a
Yeah.
cervical study,
Oh yeah, yeah.
and we
Sure.
have an idea to do AI. But coming back to the question about re-stratification, because it's
Mhm.
Bodey's lecture and it's almost philosophical. It's not because what because we did that. We have a paper just came out coming
Mhm.
from the observation that in leukemia now, you don't see the classic neutropenia with 7-3 regimen, but you see all these people with refractory AML, 30,000 WBCs, and 30% circulating blasts. So we were looking into this concept of functional neutropenia, how much the neutrophils work if you have circulating blasts. And we found the worst scenario is if you don't have neutrophils and you have blasts. The
Yeah.
second worst scenario, if you have blasts,
Mm.
despite good neutrophil numerically. And obviously, the best is what has been described by Bodey in the 60s. If you are in a remission, you have good neutrophils. So, what I'm trying to say is maybe some functional assays about your blast, your immunogenetics, or genetics of leukemia can be incorporated to the brilliant work you and others have done to clinical trials. And that begs the question. I think what I always admire about you is your energy about the clinical trial work. And how do you think a clinical trial in the future will be, since we have such much heterogeneity in the profile of people who get fungal infections? Is it going to be adaptive trials? Is it going to be some kind of the randomized control studies? Is it a thing of the past? What do you think of the future of
Mhm.
clinical trials in mycology?
Um, I guess that we should ideally start or have a thoroughly described and defined patient population with large biobanking from stool samples to blasts, so comprehensive, um, likely including environmental factors, whatever these are, and whatever rough categories for this would be. And maybe a way forward is to gather such large data set of hundreds at least of such patients and then hope that AI finds something in there that we then can use for a clinical trial. So that is, I'm very sorry. It's not a desirable answer. But
Yeah.
yeah, but so I don't, and then if one would go then in a prospective clinical trial, then that would certainly be an adaptive trial. It would be an adaptive study, um, because otherwise all the different subgroups that one would create and differentiate in that hypothetical from that hypothetical biobanking and registry study or cohort, you can do with all the results that come out of this. You can't expect that there are hundreds of patients per group, so it will be
Yeah.
in the prospective thought, it will be smaller.
You're absolutely correct. Actually, there is a paper, I don't know much about AI, when AI can generate, as they say, digital twins based on all this comprehensive assessment as
Yeah.
the control. So you can do an adaptive trial and cut down on the number of patients. This is called the digital twin concept of AI, but I claim my ignorance more than what I said. But back into your idea, AI might be empowering this type of design of trials.
And it could be that there comes a pattern as a high risk pattern that we don't understand, that
Yeah,
doesn't meet our clinical
yeah.
impression, so to say, because it goes beyond the clinical impression.
Here at MD Anderson, they had a program, maybe Bob can comment on that, about outliers. People who did so
Mhm.
bad despite the odds of doing well, or people who do so good despite
Yeah.
all their what we thought they're going to do bad.
Mhm.
And I don't know if Bob can comment on that, but on a way of learning more that what is the conventional wisdom. So here, whenever I'm in our program, we always look for these outliers. Hard to study, but we always learn something about them.
Mhm.
So I think it's something to be learned about looking for outliers.
Yeah, I mean, at the oncologic level, we certainly look at the unusual responder population in particular. Fund America has been very passionate about that for a long time, trying to
Mhm.
aggregate some data around that. Um, the idea that we should look at the unusual disasters, I think that's a I don't know if the N is
Yeah,
worse there or better.
yeah.
There are more numbers there or not.
We had a patient who died during emission induction chemo with disseminated mucor that we never seen forever.
Yeah.
And then we went back and look, and then the patient was a carpenter working on carpentry
Mhm.
and was heavily colonized as a part of his profession. And we thought he had an overwhelming inoculum and he got disseminated mucor. So we now go back to our fellows and say, make sure you always tell us about the patient profession, works in construction,
Yeah.
smokes marijuana, is a carpenter, to quantify risk at the get-go for the
Yeah.
unusual presentation.
Yeah. Is a professional gardener or
Yes,
garden landscaping. I don't know what
yes,
the precise
yes,
job titles there are, but there is a paper from Italy who analyzed that on and they found a clear association with people who spend a lot of their time outside and are working with wood and with soil and
yes. So we're almost at the top of the hour. I see no other questions. I don't know. But I think we're going to conclude here. I think we're very privileged to have you as one of the recipients of the Bodey Lectureship. Congratulations for an amazing body of work. And we'll see you soon and have the rest. I don't know, it's afternoon in Tokyo now or evening. Have the
no,
rest
it's
of
it's
the day.
11 p.m.
Okay,
So it's
okay. Have
but
a
but
good
I'm
night's sleep.
still I'm still in to me it's 4 p.m. because
Okay.
I'm somewhere in the
All
middle.
right.
Thank you very, very
Take
much.
care, okay.
Thanks.
Take care,
Thank you
Oliver.
so much.
Thank you very much for
Thank
your
you.
lecture.
Thank you.
Thank you.
Bye, Bob Dimitrios.
Bye bye
Thanks.
now.
Bye.